Thank you so much to the World Congress for inviting me to talk a little bit. You've heard from a lot of great people today. You've got a great lineup over the next couple of days. I'm totally jealous because I'm not going to be here for all of it, but I think you'll learn a lot. I know these conferences always make me very sort of nervous and agitated because as I sit there, I'm like, oh, we should be doing that. Oh, well, we're kind of doing that. Oh, well, there's no way I'd ever be able to do that. And I just, by the time I walk out, I've got 17 pages of notes, and I know if I can get one good kernel, I have learned, that's a win. And so what I want to talk about today, and I have to say that this is a very hard position to be in speaking in the lineup because I know that you are 30 minutes from drinks. So I don't know what's worse, right after lunch or right before drinks. But anyway, I'll try to keep it moving. There's a lot of slides. I'm not going to spend very long on any one slide. I break all the presentation rules, so you got to just forgive me. They'll be on the website afterwards if you want to deep dive into anything. But I think I need to pull this up. Give me 1 second. There we go. Got it.
Okay.
Very tough to have innovation in your title and not be able to run a PowerPoint. Okay. So I just want to talk a little bit about I'm going to give you a framework. And it is a framework of, you know this stuff, okay? So I'm just going to give you a framework so that when you're out there talking to the people that are making the decisions for you, or you're getting to make the decisions, or you're in a position of influence, you know where you're going. You have some trajectory. You can help people come along on the trajectory of where healthcare is going and how transformation is occurring. So sort of not forgetting the why, talking about integration. I'm really going to be focused on integration for this particular talk. And then kind of where is integration, what's the next beyond for integration and how we're approaching it. I hope that you will find in this talk and again this week that you'll find places along this trajectory I'm going to talk about where you are or where you have opportunity or where you think you need to focus next. So you all will not have done all of these integrations, but certainly at least you have some kind of a roadmap and you can point to it and say, see, this is where we have to be. In order to be here, we've got to get this. So this is the lineup, right? So just giving you stuff to talk about. So every system, right, perfectly designed to get what it gets. Healthcare has certainly been designed to be completely siloed. We've been working for now, many of us in this room, almost 2 decades, trying to get it straightened out. And we know that obviously the why we're here is because that growing GDP for healthcare spend compared to other countries. We know that even though we spend a whole lot, we're not getting the best outcomes, that there are other countries that are doing much better than us in infant mortality and years life lost and expected life expectancies. We also know that consumers are spending more money, and as they spend more money, and some of the insurance plans, obviously with the high deductibles, have been designed in such a way to force people to start spending money so that they'll pay attention. Never mind the unintended consequences of them not wanting to spend the money and then not getting their blood pressure medicine and doing all the things that are good. I still think the high deductibles are going to turn out to be bad, but we know that they are one of the pegs along the trajectory that we are on this road. But this information, this understanding that this growth in GDP and the fact that we won't have money for roads and we don't have money for education, and I know in New York that was a big deal this year because we didn't have money for healthcare because we needed to put a whole lot of money into education this year, right? So there's lots of gives and takes, and so we are being forced to be more efficient and as a healthcare delivery system for the whole United States, so not just in New York. And the drivers of change are really pushing us to transparency and cost and quality. We heard in the opening today that Dr. Badre talked about the score that people are going to get on their health, and that's going to have an impact on their insurance and their insurability. But there's also, obviously, there was the rulings around that CMS put out this year that we had to put, as a hospital system, you had to be more transparent with your costs and your charge master and all of the chaos that caused. Certainly the pressure to move from the fee-for-service to value-based, and definitely MIPS MACRA and all the torment that caused and all the reporting, and appreciate that CMS was trying to make it easy, but it's never easy. And so that drove a lot of providers out of the market, right? Sort of unintended consequences. We know that we need care coordination in order to navigate all these broken systems. If we weren't so broken and we were more integrated, we wouldn't need so much navigation. It would be more seamless. But that's a road we've got to get to. And then this focus on the transition to wellness, and we'll spend a little more time on this at the end of my presentation, and thinking about how you're getting upstream, and certainly what you just heard from Kaiser Permanente and the work that they're doing, which I completely applaud. I think it's fabulous, and love to have big systems like that helping to lay the groundwork for work that needs to get done in all of our communities. So what stakeholders started doing about some of these pressures, right? I call population health 1.0, and this is really just block and tackle, like understanding we're very siloed, we're very broken, and we've got to figure out how to become more connected, right? So we're familiar with the continuum. Each one of us sits in one of these circles as far as being part of a system. Maybe you're sitting in a system that has all of these. Rochester Regional Health is a fully integrated system, so we have all the components. And we have spent a lot of time, the last 25 years, we've been building our integration model. So this is where a lot of the work has been focused for Population Health 1.0 is how do we connect the dots? Going to talk a little bit about how over the last probably decade this has really panned out, sort of, again, big picture panned out, right? So talking about some of these different components, but what I want to spend the most of our time on is sort of what I call the last mile, which is what I would say is Population Health 2.0. So obviously there was a real recognition about patient-centered medical homes and the PCP being the quarterback, and we heard some of that today. The focus on teams, technology, and how do we leverage technology to break down some of these barriers and silos. Lots of focus on care management systems, and so I had a slide in here that I took out, but it showed the trajectory of care management acquisition by the healthcare industry, and it's doubled in the last 7 years, and this is just to show that it's going to continue to grow. So the investments that are being made in care management systems and technology currently is at about 8.1 billion, 8.2 billion, somewhere by 2024 it'll be 25 billion. So it gives you some understanding of the magnitude of work we're trying to do to glue everything back together. We know that other areas of integration we've been seeing are around how we reconfigure, how we're reconfiguring the physical assets of healthcare, of the healthcare system. So, yep, there's the workflow and the care management, but then there's also our physical assets and how that's been changing. So, co-locating services, creating ambulatory surgery centers, remodeling acute care campuses and medical villages. So what we've seen in upstate New York, and I'm sure you're seeing this in other places, is the smaller community hospitals can't survive anymore, right? Technology's become so sophisticated they can't afford it. The physicians that are coming out are more specialized. We heard that even this morning. And so in needing to be able to recruit, they just can't, even if they wanted to and had the money for the technology. And so you're seeing aggregation of the tertiary quaternary centers with everything under the sun. And then you're seeing sort of the dying of these community hospitals and their inability to make margin. And some of them are closing. That's never very popular because they're also economic drivers. When you look at the GDP and you see that it's 20%, that means in communities it is a big economic driver, the healthcare system. And so when you close one, you take away a lot of jobs. So what we're seeing is how those campuses can be helped to reconfigure themselves so that they're more ambulatory, so that they're adding ambulatory footprint, primary care, specialty services, using telehealth as a mechanism for getting specialty services out to those areas so that we don't kill the economy, but we actually help to integrate the economy, but just differently in a different way than we used to think about those community hospitals. Lots of work in the one-stop retail shop, right? So now your urgent care is on every corner where there's a Starbucks, right? We see that these ambulatory campuses, I use UPMC and Highmark as an example because they're my hometown, even though I'm currently from New York. Pittsburgh's my hometown. And when you drive down 79, you see UPMC has their full service surgery, outpatient physical therapy, primary care, subspecialty clinic, big, 60,000 square foot building on the left, and about a mile down the road on the right, there's another one, and it's UPMC's. So you got UPMC, Highmark everywhere doing these big campuses. So that's a real reconfiguration of how healthcare is being modeled or being built and rebuilt. And it's also very consistent with the marriage of payers and providers. So we're seeing more and more and more marriage of health systems with payers so that they're able to get upstream on the dollar, be able to, again, between being more efficient, but also cutting out the middleman, things like that, trying to have right pocket, left pocket moves that give them flexibility. So we're seeing, obviously, those kinds of integrations. Data sharing. So in New York, we're fairly advanced for a state when it comes to data sharing. We started with the RIOs, which were local data sharing organizations, and now we're starting to aggregate those into what New York calls the Shinies, and that's just a network of RIOs, essentially, that are sharing data across healthcare types of systems, right? So hospitals, primary care, specialty, non-specialty, pharmacy, immunizations, right, are one of the big ones that they led with to design some of this work. That's the nicest work. But obviously the point is that not everybody can be on Epic, not everybody can be on Cerner, and so we're always going to be dealing with multiple electronic medical records that need to have a mechanism for talking back and forth and sending information back and forth. That's the expectation, and that is the patient's expectation too. They do believe that if they can talk to their daughter in California using Skype, then we ought to be able to get information across the street from the specialist that isn't part of our network. So, and then Epic Care Everywhere. I don't know, how many people have Epic in the room? A lot, a lot. So Epic Care Everywhere, obviously pretty amazing. If everyone had Epic, we wouldn't need the Shinies, but again, we don't, so, but very cool. All right. We also know that it's not just about the data sharing, it's also about having functionality within the systems. And some of the big guys, Epic, Cerner, Athena, McKesson, have gotten very good at saying, okay, it's no longer just about the simple electronic medical record that sits in a hospital or sits in a primary care office, but we have pharmacies that we need to bring on board. We have urgent cares we need to bring on board. We have skilled nursing facilities that need to come on board. We have behavioral health that needs to come on board. And so there's more and more funding going into figuring out how do these large IT businesses build the platforms that we need to manage our integration, right? As we become bigger and having more services, we need an IT system that can help leverage that coming together, because why come together if you can't get some economy of scale? And so these guys are working right along with us as we're aggregating. They're building things to allow us to do that aggregation better. This is the population health management system. Some of you are familiar with Evolent. So that's just one example. They were kind of a front runner in the population health management sector. They're sort of the high-end version, right, of population health management systems. So these are growing, again, doubling, same rate as care management has been being brought into health systems. These large IT integrated workforce with IT, with BI, with AI, that work, we know, and we will see that continue to double logarithmically. This is just pointing back to data that supports what I was saying about the aggregation of healthcare. So this coalescing, this is important. So this slide's actually important. And why is it important? It's obvious. I mean, how many mergers we've seen, in the last year, and even, between pharmacies and health systems. We know that in our area alone, so we were 7 independent hospitals with primary care providers and some employed specialists, and this was just 5 years ago, and now we're like 1, right? We're 1 integrated health system. And we have seen that not just in New York, we're seeing that all over the country. Again, trying to create efficiency. But the reason I say that this is important is because you can see where we really took off in the 2000s, this aggregation. And so healthcare has had 18 years of learning how to aggregate and how do you integrate and leverage and build economies of scale with chassis that are IT, HR, billing, patient outreach, buildings, right? We've been learning how to do this in a way that other sectors of our society that are important for healthcare have not, right? So when we talked about social services, for instance, which I want to get to, they don't have the same capability or skill set. They're extremely fragmented, so as we get bigger and we need to have a food partner or a housing partner, it's very unlikely that today you're going to be able to go to one food partner or one housing partner and have them be able to handle all of your needs, especially if you're spread out over 16 counties, for instance, or across 9 states, right? And so we are going to see that evolution over time, and healthcare is going to be pushing. And I'll show you how we're doing that upstate. But in 2019, 70% of hospitals were actually part of larger integrated systems in the US. This is just some information on payers and the adoption of value-based payment models and partnerships with payers. So you can see, again, a real takeoff. Those numbers are really small, but that's right around 2012 where that jump, you see that jump. So this is ACO's number of hospitals contracts out there is the top graph, and the graph below is talking about lives and ACOs, independent ACOs. And so we've seen those numbers growing and growing and growing, again, as a mechanism for us to get control of GDP. But I want to spend some time on the last mile. So what I call the last mile of integration, and that is really how we partner with our community-based organizations, our education system, around actually being able to increase the well-being of our population, which the last talk did such a nice job of explaining the why that's important and the impact that it has the ability to have. So we know that the top 5% of the sickest folks cost the most, right? And that group is very complex. And that's just a group of patients that have a lot of chronic conditions. But as you move down that triangle, you have all of that rising risk. A lot of that is social determinants. So there's definitely social determinants that affect the highest risk patients, but we got social determinants impacting the rising risk. And we're trying so hard, our care managers are trying so hard, and we're using data, and we're using BI, we're doing outreach to try to help folks, to try to get them in for their appointments, to try to reduce their transportation barrier for their no-show. But if you can't get to upstream, sort of to the transportation barrier issue problem, it's very hard to get them into their primary care visits so that they aren't a no-show, so they actually get their medication refilled, or they have their blood pressure checked and realize that, oh, this time they actually do have high blood pressure, right? So we know it's that whole aspect is complex. And so the New York State Academy of Medicine met and talked about, okay, what's the next step, right? And so we talked about what is population health really? What does it become? And it's fundamentally improving the health and well-being of all people in a geographic area while eliminating health inequities. So I call that is population health 2.0. That is our frontier that we have to build now. Hard to build when you have graphs that look like this. So we know that where you live matters, right? And so there are areas, so the areas of red are where life expectancies are very low, right? So low compared to the brighter, lighter blue and green areas. This is, if you're a female, there are pockets of areas in this country where if you live there, you have a much lower life expectancy. Obviously, if you're from a Black or Hispanic ethnic background, you have definite disadvantages and disparities in your likelihood of living over 65. In New York, this has been a huge problem that they've been working on, and one of the dark blue areas are the areas where if you're African American you are 2.5 times to 3 or 4 times more likely to die before age 65 than your white counterpart. Wow, this sucks. We did a deep dive, so we were very fortunate to have Common Ground. It is a planning agency that does have a line item in the state budget, so that's really nice, but it's a very small aspect of the line item. I think the line item has been the thing that has prevented anyone from ever shutting them down, because they always have this line item, which is, it's about $100,000 a year, so it's like nothing. But they do a lot of data, and they convene, and they have us talk about hard issues. And so one of the pieces of work that they did was around zip codes, and they broke out Monroe County, and that's the county that is the hub for our Rochester Regional Health System. They looked at zip codes, and they said, okay, if a girl is born in Penfield, she's going to live 10 years longer than the girl who's born in the city of Rochester, and those are only 15 minutes apart by car. For those of you that don't know, Monroe County is the 5th poorest city in America for children. So these are some other poverty impacts, right? So the difference between Monroe County, Rochester City proper, and Pittsford, which is one of our suburban communities, which is extremely affluent. But you can see, when you look at all of the prevention quality indicators, the premature deaths are higher in the city, the premature births are higher in the city, later no prenatal cares, 2.5 times in the city than in Pittsford, and teenage pregnancy, is 117 per thousand compared to 3.8 per thousand in Pittsford. Our DNA is not that different, right? So getting upstream of this. So these are the socioeconomic factors. Again, 40% of your health and well-being, your outcomes, are social. Health behaviors are 30%. You got clinical care is 20%, and physical environment is 10%. What are the social determinants actually defined as? So that is the economic stability. So remember we talked about our role in closing some of the economic generators in communities with our consolidations. We are having an unintentional impact. Neighborhood and physical environment, education, food, community and social context, and healthcare systems. So creating the right balance. So I just wanted to also show something here, and that is a little bit of information around the spend for social services and health outcomes. So if you're not totally buying the whole social determinants being important, I just want to show some statistics that'll show you that they really actually are. And that is that countries that have higher ratios of social service to health spend have better health outcomes. So this is where the US ranks compared to Sweden, France, the Netherlands. We spend more, the lighter bar on the bottom, in healthcare. We spend less, the darker bar, in social services. And you saw from the earlier slides, we don't have that great outcomes, right, compared to all these other countries. We also know that as you strip away these social services from folks, like we just took SNAP, there was a big cut in SNAP, which I know that in the last presentation you saw how important that is. When you cut that, because you're going to save X amount of dollars in that line item, in that budget for that thing, we're not paying attention to what we're going to now spend in healthcare because we made that cut, and also the quality of life that we just impacted, as you saw from the last one. So this is actually work that was done by Berkowitz, and it shows that SNAP benefits improve the overall spend by $1,400 a year. So I actually did the math whenever they did the spending cut, and it was going to be, the cut was going to actually cost the government 2.5 times what the cut was. So getting to the last mile. So we need to think about how our programs are going to be focused on the whole person. You need to think about braided funding, because we can't do this alone. The health sector can't do this alone, and we need social services, and even though they don't have as much money going in their direction, they do have money going in their direction. And so what do you do whenever you don't have enough money you have to get more efficient. And so my message for you today is we can still leverage what's being spent in education and what's being spent in social services by leveraging efficiency and creating bridges and ways of communicating across these sectors, just like we've had to do with ourselves, how we've had to connect primary care doctors with the hospitalists in the acute care setting, and how we've had to connect skilled nursing facilities with hospitalists and with primary care providers, and how we've had to connect pharmacies and pharmacy information with primary care providers, right? We've been doing this work, and we now have another responsibility of how we help the social services and education do the same thing. The waiver program. So in New York, we did sign up in 2016 for the 1115 waiver. There are many states that have this now. They're in various phases of it. The 1115 waiver is a Medicaid transformation waiver it's a partnership between the state and the federal government to allow funds that would normally have been match funding for the federal government dollars that come into a state to be redeployed to do transformative work in the Medicaid space. And so New York was a big proponent early on. California, Texas, New York were the first three. There's, as I said, several more states that are involved in these. They did give seed money for being able to transform the system. And so in our area, we did use this opportunity to say, okay, we're going to take Medicaid dollars and we are going to embrace the social service areas and education and create pilots and programs to try to prove to the state, the federal government, and everybody else that if we work together, we can actually get better outcomes. Is anyone here in a waiver program? A few. We know that there's research. Some of the waiver work came out of the fact that research showing that when counties cooperate and they share resources, they drive better outcomes as far as prevention and health outcomes. This is a graph that shows some of the deltas you can see as far as spending in cancer, spending in heart disease, when you had complex services come together and create more seamless communication between them. In New York, we took in upstate New York, as part of the district work, we took a look at how we were doing in this space, because we actually thought we were doing pretty good. We thought we were much more coordinated than we were, and so we looked at how we were misaligned across many of our services, how difficult it was for our patients and residents to get benefits, to accurately report their benefits, because if they reported some of their benefits, they would lose other benefits, and so it's kind of difficult. And so we had an F in a lot of these areas. So we brought together a coalition of folks to talk about what do we need to do differently and how we're going to envision this differently. We mapped it all out and said, oh my gosh, if I was a patient and I needed social services of any kind, this is what I have to navigate in order to get there. And so you can imagine why so many of them just don't. Like the woman from the story in Kaiser that wasn't getting her food benefit, right? Her SNAP benefit. So this is crazy. And we said, this is crazy. So we said, we got to come up with a better coordinated system, and that's where we all need to row together. So we need health, education, social services, and the government services, the government agencies, the counties, to also get on board and help us. So this was a pilot. This is just one example. We've got food, education. We have some really cool pilots where the housing for patients who need assisted living or are almost needing assisted living but are still able to be in independent living, where they are trying to help nudge, I like that word, trying to help nudge some of our seniors to actually move into these housing projects, because everybody wants to stay at home by themselves, but then they're not stable and they're not safe, and it's very hard to get services in for them. Sometimes, and so if we were able to nudge them into independent living, which then we can get them into assisted living when it's time, then we can have a better outcome for them, and hopefully they can have a better quality of life. And so there's one of the pilots that I really, really like is around how to nudge people to join these housing projects, and so they've been doing a lot of work. But this was our transitional housing project. Rochester Regional Health funded this, so we just said, okay, we're taking a piece of our margin, and we were going to put it towards housing. And so we basically partnered with a housing provider locally, bought 10 beds, and took patients that were really functionally homeless, and we discharged them to this transitional housing. They got up to 90 days, and during that 90-day period, our team worked on finding them actual housing that could be more permanent, so 2 years plus. And so I show this slide just because for those of you that have a CFO that you have to prove that something can work, this is a great slide to help them understand that you can decrease length of stay, and for most hospital systems, that comes with everyone knows what a day extra costs, or provides them as far as margin, if you can gain it. And so being able to show that you can reduce length of stay, being able to show that you can reduce the number of beds used. For us, we're running at 125% occupancy, so we have people in the halls, and that's not good care. And so being able to come up with anything that helps us get throughput out of the hospital is really important. And then obviously readmissions. Now this particular population that we focused on was a little bit of a younger population, so not nearly as many chronic diseases, comorbid chronic diseases. And so our readmission rate was only decreased by 16%, but it's because I think a lot of the issues that they had were behavioral health issues, which, as you know, are very challenging. So not like congestive heart failure, where if you do just about anything with them, you can get a 50% reduction in readmission. So some of the people that came to the table, we had obviously our Medicaid waiver leadership group. That our district program was 13 counties, 600 organizations, and 7 competing health systems. We brought human services together, community-based organizations, small, tiny ones that maybe only had 10 employees, and some of our big ones like our Catholic services, right, that are many more. Our MAPI, which was a poverty initiative because the governor said to Monroe County basically like, guys, you got to fix this. You are doing a bad job. If we're the 5th poorest community in the United States, you got to fix it. And so he sent some resources over to organize work to try to elevate our residents out of poverty, because as you see, just being poor is going to drive bad outcomes. And so a lot of work there. And then we wanted to have education at the table because we were having situations, and some of you in this room may have been there, where you're in the emergency room and you have a kid and they come in and you're ready to discharge the child to somebody, but it isn't their parent. Do you know you don't even know if you can discharge them? Then you need to get them a caseworker, and then you find out, the next day that you discharged them to the wrong parent, and that they already have 2 caseworkers in 2 other places, right? There's just we're not efficient there. And we know that if we can improve their education days, they can actually have better health outcomes in the future. There's a whole lot of nurse-family partnership work in this space. So that was important. So our collective vision was to come together, and we put a congressman at the table. He comes every month to our meeting, Congressman Joe Morelli. He's fabulous, and he has been pushing and making sure that everybody sits at the table. And so I tell you that because if you can get a champion that's very well respected, and it doesn't have to be a congressman, but it's someone that yields power, money, or influence, you can bring coalitions of people together to use the funding they already have in order to make change. And you find places where you can work together differently, and you're both winning, right? You're all winning. And so that's the kind of work that this collaborative did. We have we've got a very secure process that we're using. We have functional work teams in all of these areas. So you got to change workflow. It's not just about funding. You have to look at your protocols for what do you call a front door? Who's going to be on technology? How are you going to get the technology to integrate legally? So how do you get education to be able to share information with healthcare, and healthcare to share with education, right? So these are legal questions, but we've done a lot of this work because we've had to share with people that, because of HIPAA and others, we know a lot. And so we were able to bring a lot of our experience as a healthcare industry to the table to help some of these other folks move along the platform. We know that if you don't measure it, you didn't do anything, and so we knew we needed to have some special evaluation considerations. These are our work streams, so we've got 7 of them. around making sure shared language, that was something I brought up early, because an emergency to education, when you say someone's in crisis in education, it's very different than when you say someone's in crisis and they're in the ED, or when you say they're in crisis and they're in the county, right? Those are three very different definitions of crisis, and so we had to sort of work through that. That is stuff I am not good at, and I am so glad that there are other people that have the ability and the patience to work through those kind of details, because that's the level we're actually getting down to. These were our evaluations measures that were proposed. We've got, for education, there are measures. For health, there's measures. For social services, cross-sector measures, and then process measures. Each sector weighed in heavily on what they believed needed to be their measure, but then all the sectors got to weigh in on everybody's measure so that we kind of pared it down. So this has been going on for us for 5 years. For me personally, this has been going on for almost a decade and a half, because I used to be the CEO of an FQHC. And so I'm very passionate about how do we get to this, because I couldn't help my patients as soon as they left my four walls. So for the system, so again, these are tips and tidbits that might help you in your discussion with your leadership back home, is we did learn about Epic social care and how important that was going to be, and we were able to get it prioritized in our budget to make sure that it was part of our implementation, that it was just as important as implementing the pharmacy arm of Epic for our system. We learned together with our competitor how to attack guardianship, right? So because we're a community where we have we've got the University of Rochester and Rochester Regional Health, and we both have giant EDs and giant hospitals. Our patients go back and forth because they don't really care. They just need to get to someplace that's going to take care of them. And so there's a lot of our patients where we had a lot of energy and excess work going into figuring out guardianship for children. And so by doing this work, we've been able to figure that out. So that takes a lot of work off of our social workers. Shared definitions for social care so that we are actually saving money, because the U of R is putting time and energy and effort into social care and definitions and workflow and sharing with us, and we're sharing with them. And so it's actually making it less expensive, because social care, implementing this technology that's a closed loop referral system is expensive and hard, and you have to have partners that are on the other end of the referral that have the ability and resources in order to make those connections, right? When you're asking a 10-person shop to connect to Epic, that doesn't work. So Unite Us is one that we're looking at, and I know that was mentioned in the prior talk, so that there's a smaller platform that can connect to a larger platform. And then we've been able to improve efficiency at some points of entrance for some of our patients already through this work, so it's been really great. We see being able to create an electronic chassis with good workflows, with front doors in multiple places around our communities in the 13 counties that we're serving. We see that as being able to help our social service partners aggregate, come together, just like healthcare has, but also it'll be a tool that we'll be able to see not just the healthcare system, but our whole community will be able to hold some of these social service organizations accountable for the work that they need to do, right? Because right now there's no transparency of outcomes for some of the social service agencies that we're using. And so by getting onto a shared platform, being able to have closed loop referrals and have data that we're mining and that we're reporting on, we're able to see where there are opportunities for improvement. So that's sort of the gist of it. 211 was an early leader. We learned a lot from them. They were focused on the homeless population in LA. And they've seen great reductions in hospitalization rates from their work in building a closed-loop referral system across multiple partners. There's other people that are crazy in the world with us that are trying to build these cross-sector IT platforms and workflows. And so it's been very fun to learn about these different communities and what they're doing. And so I think with that, I leave some time for questions.
Anybody has any questions for Dr. Wiefling? Oh, right there. Okay. So first of all, thank you so much. This was terrific, and with the speed of light, and you covered a lot. Thank you. So I actually have a statement to make, so please bear with me, everybody, and then a question. So I totally can relate Newark, New Jersey, and Jersey City. The way we measure the differences within a 20-minute driving distance is infant mortality, Jersey City 2, Newark. Anybody wants to take a guess? 12. So the statement is, thank you for the slide that you showed with US as compared to other countries. Not only do we contribute less to the social funding, we actually contribute the least of all the countries. Yeah. And the fundamental difference between everybody else and us is that A, we don't have a uniform healthcare system, but B, even more importantly, we don't, which I strongly believe leads to now everything that we talk about in social determinants of health, is we put our own young generation into debt because we don't have a uniform education system. All the other countries actually educate their citizens without having, you too can go to Harvard for $80,000, thank you very much, right? So my question now is, when we approach social determinants of health, but at the same time, we perpetuate the situation that if you were born in poverty without access to education, you will die in poverty. What do we think about social determinants of health? Because it's almost like putting a Band-Aid, where really giving people tools with which to improve their economic standing in the society is really a dream.
Yeah, so I have two comments to that. So number one, that's why we actually had our MAPI at the table. So that's the Rochester Anti-Poverty Initiative, because we felt that we needed the business community at the table with us. So they are part of the work that we're doing to increase jobs, to increase the minimum wage, to create workforce pipelines, because we know that any great innovation system is not just about the R&D, it's about the workforce and the enablers that go into it. And so that was an important reason we included them, for that reason, so we can try to change poverty at the same time, because we can't, you're right, we're not going to solve much if we can't solve poverty, right? So that's got to be part of the work. And then the second question I think that you were getting at was really around is it a Band-Aid, right? Is the social services a Band-Aid? And I don't actually believe it's a Band-Aid, because if we do this right, we're going to change the workflow. And so even though they don't have, maybe the social services don't have more money, we're asking them to spend their money, and we're wanting to spend our money just slightly differently so that we can try to make that more efficient. So I don't need two caseworkers, one from education and one from a social service agency, plus my care manager taking care of managing a particularly difficult case. If I can get it down to one of those three, then we've already saved some money.
Thank you so much. What I'm really saying is that is the concept of population health and addressing social determinants of health, is this not a Band-Aid when, yeah, you can give people jobs, but if they have a high school diploma, their earning opportunity is limited. Mm-hmm. So should we be addressing social determinants of health, or should we be focusing on education access?
Well, I think we have to continue to work on all of those levers.
Yeah, all at the same time,
yeah.
I would say that too, yeah. Any other questions for Dr. Wiefling? All right. Well,
all right, awesome.
have a great,
thank
you so much again, Dr. Wiefling.